Good afternoon. My name is Charles Quinn, and I have the pleasure of moderating the webinar today entitled Thrombotic Microangiopathy, a focus on atypical hemolytic uremic syndrome. And this is for the American Society of Pediatric Hematology Oncology. I have a few housekeeping items before we get started. Please note that all participants have been muted for the presentation this afternoon. I would like to direct your attention to the chat room on your screen, lower left-hand side. Please use this chat room to ask any questions, which I will direct to the speaker at the end of our presentation. You can also use this area to let me know about any AV issues or technical difficulties that you might be having during the presentation. Our speaker today is Dr. Bradley Dixon, my colleague and expert in atypical hemolytic uremic syndrome from Cincinnati Children's Hospital Medical Center. He's assistant professor of pediatrics in the Division of Nephrology and Hypertension and also director of our nephrology clinical laboratory. And I will hand the presentation over to Dr. Dixon now.
Great. Well, thank you for that introduction, Charles. I'm going to be focusing for the next 45 minutes on thrombotic microangiopathy and specifically on atypical hemolytic uremic syndrome, as well as distinguishing AHUS from other forms of thrombotic microangiopathy. But I wanted to start with a case to help illustrate some of the points that we'll be talking about over the next little bit here. So in this case, we have an 11-year-old white male who is previously healthy, and he presents to the emergency room with 3 days of vomiting and abdominal pain and develops fever and dark urine on the day of presentation. And there's no history of diarrheal illness. His review of systems is significant for a headache as well as some mucosal bleeding. And his past medical history is interesting for febrile seizures occurring 1 year ago at 10 years of age, which is a bit atypical. And he had dental extraction done about 5 days ago. And his family history is unremarkable. So on physical examination, he has normal vital signs, and notably normal blood pressure. His abdominal exam is reassuring. He has no pedal edema and no scleral icterus or jaundice. And on his initial screening labs, he has fairly pronounced thrombocytopenia with a platelet count of 18,000, a relatively mild anemia with a hemoglobin of 12.8 and hematocrit of 36.5 and a normal white blood count. He does have a substantially increased LDH, as well as the presence of schistocytes on his peripheral smear, and due to the dark urine and blood in the urine, he had a CPK done that was normal. He does have some mild to moderate renal dysfunction with creatinine of 1.42, and he has both blood and protein on his urinalysis. And so our diagnosis at this point, based on the lab findings and perhaps some of the historical and exam findings, is thrombotic microangiopathy. And now that lends us to a discussion of what is the differential diagnosis for this patient, and is there any additional workup that is indicated? So speaking broadly about thrombotic microangiopathy, this represents a convergence of many different pathomechanisms which all hinge on endothelial injury at their root. And an injured endothelial cell surface is a ripe environment for aggregation and activation of platelets, and this ultimately can lead to fibrin deposition in the microvasculature, and the microthrombi that result create shear stress to red blood cells traveling past, causing mechanical trauma, and ultimately fragmented red blood cells like these schistocytes shown here. And this occurs in many different microvascular beds throughout the body, but the renal microvasculature does seem to be particularly susceptible to this process. So thrombotic microangiopathy really represents a category of diseases rather than a disease in and of itself. And I have here shown the differential diagnosis of TMA, and I have listed in red some of the forms of TMA that are thought of as primary forms of TMA. Shiga toxin-associated HUS, primary or atypical hemolytic uremic syndrome, and both the acquired and congenital forms of TTP. But as you can see, there are a number of other disease entities that also fit under this umbrella of TMA, all of which lead to the same clinical features of consumptive thrombocytopenia, microangiopathic hemolysis, microthrombi formation, and ultimately end organ dysfunction. So just to give you some background on the history of the primary TMA syndromes, the first description of these primary TMA syndromes was in 1925, where Moskowitz described in a young girl who ultimately succumbed to her disease, fever, anemia, heart failure, and stroke. And on autopsy, this individual had microthrombi in the microvasculature of many different organ systems studied. A number of years later, the role of platelets was emphasized in this disease, and the term was coined thrombotic thrombocytopenic purpura, or TTP. Around this time, Gasser and colleagues initially made the description of the hemolytic uremic syndrome of a clinical triad, noting on histopathology platelet-rich fibrin thrombi in the microvasculature. And it wasn't for some time later that the first identification of complement, or the association with complement, was made, where a patient with hypocomplementemia who turned out to have a factor H deficiency was identified in a case of HUS without a notable diarrheal prodrome. Around the same time, an association was made between the entity of TTP with very large von Willebrand factor multimers with a hypothesized defect in the processing of these multimers, leading to microvascular thrombosis and platelet aggregation. And around the same time, a link was made between HUS, particularly diarrheal prodrome-associated HUS, and Shiga toxin-producing E. coli. So just a little bit of housekeeping here. There are some other terms for these TMA syndromes in the literature and historically that have, over time and more recently, have become problematic. And one such categorization is diarrheal or D positive versus non-diarrheal or D negative HUS. And this has become problematic in large part because diarrheal illnesses can serve as a trigger for atypical HUS, the infectious illnesses, and can also be a prominent feature of atypical HUS in a subset of cases. Another term that has largely fallen out of favor due to its problematic nature is HUS/TTP. And this is connotating a spectrum of disease where HUS and TTP are essentially the same disease but different points on the spectrum. That largely led to a categorization that HUS was a disease of childhood and TTP was a disease of adulthood, but we now know that atypical HUS can occur in both adulthood and childhood, as well as TTP can occur in both adults and children. So this spectrum, notion of a spectrum of disease has largely fallen out of favor. It's also important to point out that renal dysfunction can be severe or mild in atypical HUS, and even though CNS manifestations are prominent in TTP, they can also certainly be seen in both Shiga toxin-associated and atypical forms of HUS. So in modern terminology, the preferred terms are atypical HUS, TTP, and Shiga toxin-associated HUS or STEC-HUS. So why does it matter? Why is it important to categorize these diseases and have a definitive understanding of what the disease is? Well, it's certainly well known that TTP, but also atypical HUS, have significant morbidity and mortality if patients are not correctly treated. And we also know that intervening early with specific therapy can help mitigate against long-term morbidity and organ damage. And now that we have some additional therapeutic tools available to us, there are some therapeutic implications of being certain of our diagnosis, in that plasmapheresis is still considered the standard of care for TTP, whereas there are other agents currently available for atypical HUS directed at the complement system, notably Equilizumab. And lastly, there are some prognostic implications of diagnostic certainty, in that both atypical HUS and TTP are diseases that are likely to have a recurring course throughout an individual's lifetime, whereas Shiga toxin-associated HUS is really more considered a one-and-done kind of disease. So there are some basic clinical guidances that can help us distinguish between atypical HUS and TTP in an acutely ill patient. One such feature is the platelet count, which tends to be more mildly decreased or even normal in patients with atypical HUS, whereas it's more prominently decreased or severely decreased in TTP. Lung involvement, when it's seen, is much more in keeping with atypical HUS, and it's hardly ever seen in TTP. The renal involvement does tend to be generally prominent in atypical HUS, whereas it's generally mild in TTP. And conversely, CNS involvement tends to be mild or uncommonly seen in atypical HUS, whereas it's usually prominent in TTP. Now, I do have to point out that these are highlighted in that they're or underlined in that they're generalizations, and there are certainly exceptions to these rules. So speaking specifically about atypical HUS, focusing on the clinical features, the onset of this disease does tend to be fulminant in the overwhelming majority of patients, although it can have a more indolent presentation in a minority of patients with fluctuating platelet counts. Most patients with AHUS do present with the complete clinical triad of microangiopathic hemolysis, thrombocytopenia, and acute kidney injury. But extrarenal manifestations are a prominent feature of AHUS, in that CNS involvement or cardiovascular involvement may occur in about 20% of patients, depending on the series that you read. And diarrhea may be a presenting feature in about 30% of patients, again, helping to break down the older term of diarrhea positive versus diarrhea negative HUS. And one of the most vexing aspects of atypical HUS, particularly for me as a pediatric nephrologist, is that it has a very high recurrence rate in the kidney transplants. So it's been long associated that atypical HUS is linked to a defect in the regulation of complement biology, specifically of the alternative pathway of the complement system. And this is because up to 70% of patients with atypical HUS have some identifiable defect in complement regulation. In general, a triggering event is necessary to bring about a disease manifestation, but this can be from a wide variety of insults, a variety of infections, medications, surgery, and pregnancy, among others. And if complement is activated and there is a defect or a failure to re-regulate complement once it's activated, complement can be inappropriately activated on the endothelial cell surface, leading to endothelial cell injury and ultimately all of the features of TMA. So to speak more definitively about the complement system, and I'm not sure that this graphic is going to show up. The first aspect of complement that's activated is C3. And C3, when it's hydrolyzed in plasma by water attack by a process known as the tickover mechanism, creates C3b and C3a. And C3b has a reactive thioester moiety that allows it to bind to a cell surface. When in the presence of factor B is cleaved by another molecule that's hidden here, factor D, into the BB fragment, and the combination of C3b and BB makes up a C3 convertase. So this is an engine by which new molecules of C3 are converted to C3a and C3b. And each new molecule of C3b can then bind to a new molecule of factor B. And hopefully this can give you a sense of how this alternative pathway is also known as the amplification loop, by which a few molecules of C3b that are spontaneously activated can lead to millions of molecules of C3b in very short order. Once C3b is bound to factor B and a second molecule of C3b, it forms a C5 convertase, where C5 is cleaved into C5a and C5b. And C5b ultimately forms the anchor for the membrane attack complex, by which C6 through C9 form the lytic pore, causing cell death. And this complex C3b-BB has a relatively short half-life and but is stabilized by piperidin. So how is the complement system regulated? Well, this happens through a variety of both fluid phase and membrane-bound regulators. So C3b, when it's on a cell surface, is bound by membrane cofactor protein here, as well as thrombomodulin. And both of these molecules serve as a docking station for factor H. Factor H itself is a cofactor for factor I, which enzymatically cleaves C3b into its inactive form, IC3b. And the C3b-BB complex can be dissociated by decay accelerating factor, or CD55. And I'll just point out that this molecule is one of the cell surface deficient molecules in PNH. So for a long time, the dogma was that atypical HUS was exclusively a disorder of the complement system. And some recent discoveries have largely helped to show us that this is more complicated. And that discovery was really primarily by identifying diacylglycerol kinase eta, or DGKE is the gene name, in a subset of patients with atypical HUS. And this protein is an intracellular enzyme that regulates protein kinase C. And when this enzyme is defective, protein kinase C is uninhibited in its activity, and this creates a prothrombotic environment at the cell surface. And as best as we can tell, there is no association at all with diacylglycerol kinase eta and the complement system. And so mutations in diacylglycerol kinase eta have been recently described in a cohort of patients with atypical HUS. And these are patients with an autosomal recessive inheritance pattern with complete penetrance. And this was described or identified initially by whole exome sequencing. And these patients tended to present within the first year of life and had persistent urinary abnormalities, both microscopic hematuria and proteinuria, following their initial disease presentation. But fortunately, this form of atypical HUS does not seem to recur after kidney transplantation. And this inheritance pattern and penetrance is somewhat in contrast to other forms of atypical HUS, which have a more an inheritance pattern that is more of an autosomal dominant pattern with incomplete penetrance. So based on this understanding that there may be some interplay between the coagulation and complement system in atypical HUS, this has really evolved in this understanding. Thrombomodulin, being one of the genes that has a role in controlling the complement system, also has a significant role and its first described role in controlling the coagulation system. Again, as I mentioned, mutations in DGKE seem to confer a prothrombotic state, but do not seem to participate in regulation of the coagulation complement system. And then more recently, Richard Smith and his colleagues at the University of Iowa identified mutations in plasminogen in a cohort of adult atypical HUS patients, looking at both coagulation and complement genes by massively parallel sequencing. So when we're faced with a patient with thrombotic microangiopathy, there is a series of diagnostic steps that are appropriate. First and foremost, we want to look for secondary causes of TMA like pneumococcal infection, HIV, lupus, and others, because treatment, by and large, treatment of those underlying conditions are the appropriate treatment for the TMA. It's a robust evaluation of the complement system is appropriate to investigate for the possibility of atypical HUS. Investigating ADAM-TS13 activity is appropriate to evaluate for TTP. And lastly, looking for Shiga toxin is appropriate to evaluate for STEC HUS. Okay. So in terms of evaluation of the complement system, some of the oldest methods in use were functional assessments, specifically hemolytic assays like a CH50, which interrogates the classical pathway, and an AP50, which interrogates the alternative pathway. Some of the drawbacks of the use of these functional or hemolytic assays is that they're highly dependent on systemic consumption of complement components to be abnormal. And so if the consumption of the complement components is not outstripped by the production, these assays may not be abnormal. There can also be significant variability in these assays depending on how the assays are done. More recently, use of these functional hemolytic assays have developed a role in monitoring patients with Equilizumab therapy, in that these hemolytic assays should be strongly suppressed in the presence of C5 inhibition. Some additional assessments of complement in TMA include quantitative assessments. Serum C3 and C4 are measured widely by many clinical laboratories, and this can help distinguish between classical and alternative pathway activation. A low C3 and normal C4 would be more in keeping with alternative pathway activation rather than classical or lectin pathway activation. But again, this is highly dependent on systemic consumption of C3 and C4. And as a result, the C3 level can be variably decreased and may be normal in patients with atypical HUS. Similarly, we can measure serum levels of factor H, factor I, and factor B because they're circulating proteins. And factor H may be decreased in patients with factor H mutations, similarly factor I, although there are also patients with qualitative defects from mutations in these proteins where the expression is normal, and so the serum level as a result may be normal. And factor B can be decreased if it's being consumed by alternative pathway activation, but this may not always be the case. It is important to point out that these serum levels may normalize if plasmapheresis is performed, particularly with FFP, before a sample is drawn. So it's important to do this sample, to obtain the sample before plasmapheresis is obtained. Membrane cofactor protein is a membrane-bound protein, and so we can't measure this by serum testing, but we can measure it by flow cytometry on circulating cells like lymphocytes and neutrophils. And in general, expression is about 50% of normal in patients with heterozygous mutation, although it can be normal if there's a qualitative defect of the protein, but not a quantitative defect. Factor H autoantibody may be present that neutralizes factor H, which is an acquired rather than genetic form of atypical HUS, but these autoantibodies may not always be biologically relevant and can be detected in normal individuals. So again, with factor H autoantibodies specifically, it's important to obtain this serum sample before plasmapheresis is performed because this can normalize particularly a low titer factor H autoantibody. So perhaps the most comprehensive way to investigate the complement system is by mutational analysis. This is with investigating, in our center, 10 genes: factor H, factor I, CD46, factor B, C3, and thrombomodulin, as well as DGKE and 3 of the factor H related proteins. It's important to point out that both thrombomodulin and diacylglycerol kinase eta are either expressed in non-circulating cells or are intracellularly expressed, and so genetic testing is really the only way to assess for defects in these genes. And this genetic testing may have some prognostic importance in that it can help guide an understanding as to the risk of progression to end-stage renal disease, in that patients with factor H tend to have the most severe course with the progression to end-stage renal disease, followed by patients with factor I and B mutations. Patients with atypical HUS with no genetic defect tend to fall in this middle ground, and then diacylglycerol kinase eta and MCP tend to have a less severe course. Similarly, genetic testing can inform transplant recurrence risk in that the circulating factors like factor H, I, B, and C3 tend to have a greater transplant recurrence risk than DGKE and membrane cofactor protein. So what are some of the downsides to mutational analysis? For one, it's quite time-consuming in that in most labs it takes weeks to months to get this information back. And so it doesn't really inform acute management, management in the acute setting, although the turnaround time does seem to be getting better with the application of next-generation sequencing techniques and more rapid bioinformatic approaches. The other major drawback to mutational analysis is that it's quite expensive, and insurance companies may not cover this testing. Some additional challenges to genetic testing. One is that even though we go looking for it, we don't find it, in that mutations may not be identified in 30 to 40% of patients with atypical HUS. So the lack of a mutation does not exclude atypical HUS or indicate a lack of efficacy of Equilizumab. Similarly, we may get an answer that we're not really sure what to do with, like fruitcake at the holidays. If we do identify a variant, it may or may not be biologically relevant, and this leads to the dreaded variant of undetermined clinical significance, in that there are synonymous variants where there's no amino acid change that have been associated with atypical HUS in the published literature. There are non-synonymous variants in which the bioinformatic algorithms disagree on whether that variant is pathogenic. And there are also non-synonymous variants that are quite common in the population, which would be more considered a polymorphism. So the most recent development in the evaluation of the complement system in TMA is looking at complement activation biomarkers. And some of the biomarkers I've listed here, soluble C5b through 9, or the soluble membrane attack complex, and C5a, are both markers of terminal pathway activation. And these markers are particularly useful in that they're suppressed by adequate levels of Equilizumab, and so they do have some utility in monitoring patients on Equilizumab therapy. The BB fragment of factor B is a specific marker for alternative pathway activation, and it can help assess whether a patient's complement system is activated, particularly alternative pathway. And then some other markers of complement activation like C3a, IC3b, C3c, and C3d. C3 fragments are markers of proximal pathway activation that are irrespective of the activating pathway. So touching briefly on TTP, as I mentioned previously, this was linked to the presence of ultra-large multimers of von Willebrand factor in the early 1980s. And the theory of the pathogenesis is that these multimers, which unfold under shear stress in the microvasculature, remain uncleaved and create a binding surface both to the endothelial cell as well as to platelets, leading to platelet aggregation and microthrombi formation. And this led to the discovery that the defects in the von Willebrand factor cleaving protease ADAMTS13 is largely responsible for TTP, either due to a deficient enzyme in congenital TTP or Upshaw-Schulman syndrome, or inhibition by neutralizing autoantibodies in idiopathic TTP, as discovered by Drs. Tsai and Furlan in the late 1990s. So how do we evaluate patients for TTP? Well, the diagnosis is largely clinical, similar to atypical HUS, but some historical testing methods included agarose gel electrophoresis of von Willebrand factor multimers, and this is an example of such an electrophoresis showing an overabundance of the ultra-large multimers. Other historically used methods include the ristocetin cofactor assay and collagen binding assay, although these are somewhat technically difficult and have a great deal of intra-lab and intra-assay variability. But more recently, the biology of ADAMTS13 has been exploited to help standardize this testing. And currently, the most common method to test the activity of ADAMTS13 is to look at its enzymatic activity by cleavage of an artificial substrate of ADAMTS13 called FRET BWF73. And using this substrate, normal result would be greater than 67% activity in most labs, and TTP would fall in this severely deficient category of less than 5 to 10% activity, depending on the reference lab in question. I do want to point out that ADAMTS13 activity can be decreased, but mildly or moderately so in a number of other diseases that aren't TTP, including DIC, liver dysfunction, sepsis, pregnancy, and both atypical HUS and Shiga toxin HUS. So evaluation for Shiga toxin is the gold standard or historically used test with stool culture using sorbitol McConkey agar. And this is based on the principle that the vast majority of E. coli isolates ferment sorbitol, whereas E. coli 0157H7, the most common serotype in the United States that expresses Shiga toxin, does not. And the failure to ferment sorbitol causes metabolism of an alternative food source in the agar, leading to a pH change, an indicator change in the agar. Some of the major pitfalls of this approach is that it can be negative in a significant number of patients with Shiga toxin-associated HUS, and that's because this tends to be a latent disease occurring 5 to 7 days after the onset of diarrhea, and so enough of the bacterial load may be shed to where it can't be cultured out. A second significant pitfall is that it can be negative in non-0157H7 strains that produce Shiga toxin but also ferment sorbitol, and a notable example of this is the serotype that was responsible for the German outbreak in 2011. So it's now widely accepted that an additional test looking specifically for the Shiga toxin is appropriate. And this can be either done by an immunoassay looking for the Shiga toxin protein or by PCR looking for the Shiga toxin genes. And both of these methods are highly sensitive and specific. So coming back to our case presentation, our patient had an ADAMTS13 activity that was sent and was normal, so we could reasonably confidently exclude TTP. He had a stool culture as well as Shiga toxin testing performed that was negative, but lo and behold, he had a decreased C3 and normal C4, suggesting activation of the alternative pathway. His quantitative factor levels were normal. His factor H autoantibody was negative, but he had reduced expression of CD46 on his circulating mononuclear cells, and this led to the identification of a mutation in MCP, so his ultimate diagnosis is atypical HUS. So now that we've made a diagnosis, how do we treat this patient? So the standard of care for atypical HUS for many years was plasma infusion and plasmapheresis. And the anecdotal reports of its success go back more than 30 years now. And the presumed mechanism of action of plasmapheresis and plasma exchange and plasma infusion is providing non-mutant complement regulatory proteins, and in the case of plasma exchange, also removing the mutant factor or neutralizing the autoantibody. So in terms of its efficacy, there are certainly ample anecdotal reports of its efficacy, although there are no well-controlled prospective trials showing it to be efficacious. There are two early prospective trials in the late 1980s that compared plasma therapy with supportive care alone in HUS, and there did not appear to be any benefit in death, end-stage renal disease, proteinuria, or hypertension. But it is important to point out that in these two prospective trials, there was no effort made to distinguish between Shiga toxin-associated HUS and atypical HUS. And as we can predict that the vast majority of patients in these prospective trials had Shiga toxin HUS and not atypical HUS, it may be hard to glean an understanding from this data. Plasma therapy likely has very little role in atypical HUS caused by a membrane-bound factor like MCP or thrombomodulin or an intracellular protein like diacylglycerol kinase beta. So what are some of the accepted benefits of plasma therapy? So it certainly does enjoy anecdotal evidence of its efficacy. It's also the first-line therapy for TTP, and so there's diagnostic uncertainty because of the clinical overlap. This therapy may be initiated for both diseases, and this therapy is widely available at most pediatric and adult centers around the world. Some of the significant drawbacks to plasma therapy include catheter-related complications as well as allergic reactions to plasma. And of course, some patients do demonstrate ongoing disease activity despite receiving plasma therapy. And if they do have a response to therapy, they may relapse once the therapy is withdrawn. And plasmapheresis specifically can be technically challenging in small children due to catheter-related issues. So more recently available as a therapeutic option in atypical HUS is Equilizumab, which is a highly humanized monoclonal antibody against the complement protein C5, and this received FDA approval for atypical HUS in 2011. And the mechanism of action is binding to C5, preventing conversion to C5a and C5b, ultimately preventing formation of the membrane attack complex. And then it's important to point out that this targets the terminal pathway of complement, so the proximal pathway by which pathogens can be opsonized through C3b is still preserved despite patient being on Equilizumab. So there are, unfortunately this graphic won't show up either, but there are two prospective adult trials that were performed with 37 patients, and this was published in the New England Journal a number of years ago. And this is both in plasma-responsive patients who were plasma-dependent, as well as plasma-refractory patients who had deterioration clinically despite being on sufficient plasma therapy. And then more recently published in Kidney International was a prospective trial in children with 19 pediatric patients. And so from these trials, Equilizumab was shown to be efficacious both in terms of normalization of the hematologic abnormalities in 80 to 90% of both adult and pediatric patients, as well as renal improvement in that the mean estimated GFR improvement was quite profound in patients, adult patients who are plasma refractory, as well as the pediatric patients who tended to be started on this therapy earlier in their disease course. But there was even a modest improvement, further improvement in renal function in patients who are plasma dependent, who were seemingly stable on plasma therapy. And for me as a pediatric nephrologist, it's perhaps most notable to see that 4 or 5 adult patients in the adult trials and 9 of 11 pediatric patients in the recently published pediatric trial who are on dialysis were able to come off of dialysis. So what are some of the benefits of Equilizumab? So it's a very well-tolerated infusion. It can be given by peripheral IV. It has a relatively short infusion length, and no premedication is necessary. And this is in contrast to many of the other biological agents that we use in clinical medicine. It does seem to be highly effective even in patients with severe end organ involvement. And it does seem to be effective both in patients with a known identified complement mutation or defect and in patients with no known complement defect. Some of the detractors of Equilizumab includes the risk of invasive meningococcal disease due to the complement inhibition. It's an extremely expensive medication with over $400,000 a year for an adult, according to Forbes magazine. And as a result of primarily the expense, there's an ongoing debate as to the optimal length of therapy and whether patients can be safely withdrawn from the therapy. And we certainly know that similar to plasma therapy, withdrawal of the drug may lead to relapse of the disease in some patients. So just a word about liver transplantation. This has shown some benefit in patients with atypical HUS, primarily because the regulatory factors, the circulating regulatory factors, factor H, I, B, and C3, are all produced by the liver. And so providing a healthy donor liver that makes normal amounts and normal forms of this protein may reconstitute the complement regulation and cure the disease. Liver transplantation likely has very little role in some of these forms that the complement regulators are membrane bound. Some of the earliest reports of liver transplantation were met with significant perioperative morbidity and mortality, specifically from CNS complications, but later experience has had more promise, particularly with intensive perioperative therapy. So what's coming down the pipeline for atypical HUS? There is in development a pooled factor H concentrate as well as recombinant factor H. This has been in development for some time, and this may particularly have a role in patients with factor H caused disease. There are genetically engineered fragments of factor H that have shown some efficacy in vivo models of atypical HUS. TT30 is a second generation complement inhibitory molecule consisting of a complement binding module of the complement regulator CR2 and the inhibitory domain of factor H. There is a membrane-targeted soluble CR1 called Marococept that is still in development. Recombinant soluble thrombomodulin may have a role, particularly in those patients with thrombomodulin-mediated disease. Some newer agents have recently shown promise, including a peptide C5 inhibitor and a small molecule factor D inhibitor, which is oral. So just to end with a thought of what is the role of a hematologist versus a nephrologist in the management of patients with atypical HUS. And I think that both specialties do have something to bring to the table. So what can a hematologist bring to the table? They certainly have greater experience with TTP. There's a greater depth of understanding of the pathomechanisms and differential diagnosis of some of the hematologic features of AHUS. And there may be a better understanding overall of the diagnostic evaluation of TMA, particularly through their experience with TTP. What can a nephrologist bring to the table? Certainly, we have a greater experience with Shiga toxin-associated HUS. We may have a greater depth of understanding of pathomechanisms of renal dysfunction. And due to the role of complement in other kidney diseases, we may enjoy a better understanding of the inner workings and mysteries of the complement system. And we're fortunate here at Cincinnati Children's to enjoy a team-based approach to patients with TMA, and this is through collaboration between hematology, nephrology, as well as our critical care colleagues who are all tuned in to diagnostic and management of TMA. And so with that, I thank you. Oh, and one last slide, sorry. So I just wanted to summarize with the diagnostic evaluation of TMA as it relates to laboratory investigation. And in atypical HUS, this consists of quantitative testing, both of serum proteins as well as membrane cofactor protein on circulating mononuclear cells, factor H autoantibody testing and mutational analysis, Shiga toxin testing for both by stool culture as well as looking specifically for the Shiga toxin protein or gene, and then looking at ADAMTS13 activity as well as looking for inhibition by a mixing study and or an autoantibody ELISA to investigate for TTP. And those I've marked here with an orange asterisk, I do again want to reiterate that these tests should be obtained prior to the initiation of plasmapheresis for them to be the most informative. So with that, I thank you, and I'll be happy to take your questions.
Okay, thank you, Dr. Dixon. I want to remind the participants to use the chat room to raise questions or make comments. I see at least one of you has already asked a question, and we'll get to that shortly. But to begin, Brad, I had a question and a comment about the presence of renal insufficiency or uremia at the time of diagnosis, and I think it's relatively easy to make the diagnosis of AHUS when all the features are present, but there may be some of the features don't all present at the same time. I wonder if you would talk about that.
Sure. Certainly the biology and clinical features of atypical HUS are not limited by my lack of imagination. I would say that the understanding that atypical HUS was in the context of the full triad was an earlier understanding of the disease. And I think that led to a sense that atypical HUS is more rare than it actually is. Now that we understand better about the diagnostic evaluation of complement in TMA, and we also understand the role of complement conditions that activate complement, like lupus, for example, we're able to learn that atypical HUS can manifest with different features at different times. Now, as to why it presents in some organs in some individuals and not in others, I think that is still a matter for research. We do tend to think that membrane cofactor protein, for example, patients with membrane cofactor proteins tend to have a more mild renal involvement, and so in some cases, patients like this, and like in the case I presented, could be at least clinically diagnosed as TTP, even though the laboratory investigation would suggest otherwise.
Okay. A question from the audience is, what is the evidence for or against a final common pathway in the various TMA syndromes?
Yeah, so I think there is really evolving ample evidence that complement is a mediator of many, if not all, of the various TMAs. So there's certainly ample evidence that complement plays a role in Shiga toxin HUS. It's perhaps not the driving factor of pathology in Shiga toxin HUS, but we know that factor H, for example, binds to Shiga toxin, and Shiga toxin can inhibit factor H's functionality. And we've identified increased levels of complement split products like soluble C5b-9 and BB in patients with Shiga toxin-associated HUS. Similarly, those same complement activation products have been identified in patients with TTP in their acute phase of their illness that improves in convalescence with plasmapheresis. And certainly within our own center, but in other centers, there is evolving understanding that transplant-associated TMA, for example, is a disease that is facilitated by complement.
Okay. Again, I'm reminding the participants, if they have questions, to put them in the chat box. I just see one just popped up here, and this is part of was related to the question that I'd asked earlier about uremia not being present at the diagnosis in a significant fraction of individuals with AHUS. The question is, can you comment on the hemolytic non-uremic syndrome that was described as in some case reports?
Sure. I would say that I would not say that it is physiologically distinct from AHUS. I think it is perhaps the severity of the illness, the severity of the disorder may be as a spectrum, even if the disease itself is very well characterized in terms of its pathobiology. So again, patients with membrane cofactor protein, for example, can have a much more mild renal phenotype than patients with factor H, for example. And there are certainly reports of patients who have, at least by all accounts, no evidence of renal involvement, although I would say that is certainly the exception rather than the rule. And
as the Chen et al. 2012 manuscript, I believe that they were inferring the lack of renal involvement by a normal creatinine and BUN rather than other formal measures. That's probably insufficient to exclude renal damage, right?
I would say so. I mean, we know from the nephrology world that creatinine is actually a fairly poor indicator of renal dysfunction, especially acute renal dysfunction. I mean, it's cheap. It's historically very well validated, but you have to lose a significant amount of functional renal tissue before creatinine ever changes. I think the statistic that my colleagues who study AKI would quote is about 50% of loss of functional renal reserve or renal parenchyma before you ever see a change in creatinine. There may be more sensitive indicators. We use cystatin C quite a bit at Cincinnati Children's, but it's certainly more expensive than creatinine, so it has its drawbacks as well. I would also say it's important to point out that renal involvement can also be defined as evidence of hematuria and proteinuria. So even if you don't have overt evidence of reduced glomerular filtration, you may still have some subtle evidence of renal involvement by urinalysis abnormalities.
Very good. Any other questions from the group? I'll give another minute for them to write, but in the meantime, I wanted to ask you about what should we expect now for turnaround time for Adams TS13 levels, complement levels, and complement activation biomarkers. I know that varies by institution, and we're able to get things very quickly here within a day or two, so that informs our acute management. But how does that vary across different centers?
Yeah, so I guess as the director of the nephrology clinical laboratory here that performs all of these relevant tests, I'll make a shameless plug that we have excellent turnaround times for all of these. As far as what would be a standard expectation, I think particularly Adam TS13, there should be a standard expectation of that test being available, the results of which being available within 24 hours. And that's particularly true so that more definitive decisions regarding treatment can be made. If there's diagnostic uncertainty between TTP and AHUS, I think one would want to know fairly quickly what it is they're dealing with, so that plasmapheresis, if it's not being efficacious, can be abandoned for other therapies if the ADAMTS13 activity is normal, for example. In terms of the complement activation markers, there's quite, for one, there aren't that many centers in the United States anyway that run that test. I can think of about 3 between Iowa, Cincinnati, and National Jewish in Denver, and there's a great deal of variability in terms of the turnaround time for those assays. I believe we have the shortest turnaround time as far as that goes of a week or less, but that's changing all the time as volume dictates increased number of runs per week.
Okay, another question is a practical question about the best blood samples to store before beginning plasmapheresis. There's a question, is plasma from an EDTA sample, is that any better than citrate?
Yeah, so, that is somewhat dependent on the test in question. So if we're talking specifically about complement testing, both a serum sample and an EDTA plasma sample are necessary. The serum sample, a gold top or red top tube, would be appropriate for testing some of the quantitative serum levels like C3, C4, factor H levels, etc., the factor H autoantibody. But serum is not a particularly useful matrix in which to measure the complement activation biomarkers because you do get some autoactivation of complement in the process of creating serum through clotting in the tube. So EDTA plasma is really the best specimen for those split products, particularly because the chelation of divalent cations helps to keep the autoactivation at bay. EDTA plasma is not a good sample to test ADAMTS13 on, however, because ADAMTS13, the enzyme, is highly dependent on calcium for its efficacy. So if you perform ADAMTS13 activity on EDTA plasma, you'll get a 0% activity. So a citrated tube is also necessary for ADAMTS13 testing specifically.
Okay, I think we'll have time for just one more question. So you have 2 minutes to answer this very simple question. Can you comment on the administration schedule of Equilizumab as well as the duration of therapy, and does insurance cover the costs? I'm sure you can talk for more than 2 minutes, though.
Okay, well, I'll give it a go. So I would say, by and large, in atypical HUS, the administration schedule as set out by the package insert is appropriate. We certainly see clinical efficacy with that schedule. However, there are some patients who show signs of complement activity breakthrough before their next scheduled dose, either during induction or the maintenance phase, the every other week maintenance phase of their course. And so that's one of the settings in which testing like an Equilizumab level, which we have available in Cincinnati, or testing soluble C5e through 9 and CH50 as a trough to assess whether there's breakthrough activation is appropriate. In terms of duration of therapy, in most patients, it's going to take me longer than 60 seconds to address that. I would say that there is a great deal of variability. In patients with membrane cofactor protein mutations, for example, I think the majority of those patients could safely be withdrawn from therapy after a course of say, 6 months. Whereas I also think there are patients with factor H mutations, for example, and particularly those who have a kidney transplant where withdrawal of therapy at all would be inadvisable. And the rest of the patients probably fall somewhere in the middle. I think if you're entertaining withdrawal of therapy in any patient, a frank discussion with the patient of the potential risks of reactivation and the necessity to reinitiate therapy should be entertained. As far as whether insurance covers the cost, it's been my experience personally with my patients that it is covered by insurance, but that may, and I know Alexion works extensively with insurance companies to ensure that the drug is covered, but I certainly can't speak to that being universal.
Okay, well, it's 5:01, so I'd like to thank everyone for joining us. And a quick reminder that the next ASPHO webinar is Current Issues in Oncofertility, and that's on April 7th, same time. Thank you very much.
Thank you.